All right. Let's see. We're going to start talking about some pediatric emergencies, and this is such a lengthy topic that I have divided it into two shorter 45-minute, 1 hour presentations. So, pediatric emergencies 1 will kind of look at the developmental issues concerning the pediatric patient and how, as they grow, their treatment may change. Certainly, their equipment changes. And what to expect in pediatric emergencies. Part 2 will deal with specific types of pediatric emergencies. Part 1 will be just a general overview. So the pediatric patient is called different things depending upon their age. A newborn or an infant is from birth to 1 year of age. Toddlers are from 1 to 3. Preschool are from 3 to 5. School-age children are from 6 to 12. Adolescents are 13 to 18. So even though we think that, perhaps a 17-year-old, is an adult in some eyes, you're still considered a pediatric patient until after you turn 18. Because the pediatric patient's vital signs differ from adults. When we learned adult vital signs, we learned that the normal respiratory rate was, 12 to 20. We learned that the normal pulse rate was 60 to 100. We learned the normal blood pressure was 120 over 80, those sort of things. Children, depending upon their age, their vital signs will differ. As a general rule, we don't want to rely on memory to determine whether or not their vital signs are normal during an emergency. We need to be able to access charts or things that would let us know what is a normal vital sign for a child. As an example, if you had an infant that had a heart rate of 160, that could be normal. Whereas if we had an adult with a heart rate of 160, we'd be in trouble. So infants and children differ from adults in psychology. They differ from adults in anatomy and in physiologically how their bodies work. So understanding the differences, both psychologically and physiologically, will help you assess and care for your young patients so that caring for a young patient isn't such a frightening ordeal. Now, depending upon the age of the patient and the size of their head, when you take an infant and you lie them flat on their back, if they've got a large occiput, the back of their head, it will hyperflex their head, tipping their head forward, obstructing their airway. So knowing that, we may need to position some towels underneath the shoulder of that size child, whereas some larger children, you may have to put a towel or something under the back of their head to get them into a sniffing position. Now, children's heads are proportionally larger and heavier than adults until about the age of 4. So until about the age of 4, suspect a potential for a head injury or a neck injury, particularly a neck injury, because of their undeveloped muscles that support the head and the weight of their head in proportion to the rest of their body. Infants have soft spots, which we call fontanelles, and these are areas where the bones of the skull have not yet fused together. So, in a infant, if the fontanelles are sunken in, that might be an indication of blood loss or hypovolemia or dehydration. Whereas if the fontanelles are bulging, that may be an indication of hypertension, high blood pressure, or a head injury. Now, the mouth and nose are smaller, and because they're smaller, they're more easily obstructed. So even small amounts of mucus or snot can completely obstruct an infant's airway. The tongue takes up more space proportionally in their mouth than the tongue of the adult. So the tongue is a very common form of airway obstruction in unconscious children. Typically, the younger they are, the more they breathe through their noses rather than their mouth. They don't develop mouth breathing until they're a little older, and they typically rely on their diaphragm in order to breathe. Their intercostal muscles are not well defined, so they rely on that diaphragm to breathe. Their trachea or their windpipe is shorter, it's more flexible and narrower, so it too is more easily obstructed by swelling or foreign objects. Their chest wall is softer. As a result, they can suffer significant trauma to the chest without actually breaking a rib and still have internal damage to the organs below. Their chest is shorter and located adjacent to a very full abdominal cavity. And because of this, their abdominal contents prevent the diaphragm from dropping far enough to give them good lung capacities. So infants and younger children breathe primarily with their abdomen with their diaphragm. And when the need to increase their rate and depth of breathing occurs, when they work that diaphragm hard, it's going to push all those abdominal contents down and out. So their belly protrudes when they take a deep breath. Their diaphragm is flat. Our diaphragm is domed. And so the harder they work the diaphragm, the more they push those abdominal contents down and out, and the more their chest sinks in rather than expands outward. So you get what's called seesaw breathing. The belly pouches out, the chest sucks in, and it's normal in infants, but as they get a little older, if it's drawing your attention, if you can clearly see seesaw breathing, you know that they're working hard to breathe. Their ribs are more box-like, and this limits their ability to take a deeper breath along with their abdominal contents. Because infants are nose breathers, again, very easy to become obstructed if they get secretions in their nose. And if you tilt their airway too far forward or too far back, you risk causing an airway obstruction by kinking the trachea. We don't do blind finger sweeps in children trying to clear an obstructed airway because our finger might push the obstruction further back and wedge it in the narrow trachea. So here's just a picture of the comparison between the adult and the child. Notice how much little room or how little room there is in the mouth of a child compared to the mouth of an adult, and how their trachea is much shorter, how their tongue is much larger, and can easily obstruct their airway if they're lying flat on their back and unresponsive. Now, the chest and abdomen are less developed, they're more elastic, and again, the issue with this is they can receive a blow to the chest or abdomen, not really show external injuries, maybe a bruise, but no broken bones, those sort of things, and have significant injury to the organs beneath. Their abdominal organs are less protected than adults, and in smaller abdomens, they're closer together. So when a baby takes a blow to the abdomen, it might damage their liver, their spleen, their pancreas, whereas if an adult takes a blow to the right side of their abdomen, it may just be their liver because their other organs are farther away. Their body surface area is less than adults in proportion to mass. So what that means is that children's body surface area, the amount of skin that they have exposed, is skewed compared to their overall weight. Because of this, they can easily lose heat to the environment and can quickly become hypothermic. They have less blood volume than adults, so even a small amount of blood loss in an infant, 3 teaspoons in an infant, could be significant enough to be considered life-threatening. So here's the amount of blood volume that certainly a newborn has compared to a 125-pound adult. So you can see that they can't lose near as much blood before we start to see signs of shock. When we look at psychological and personality characteristics of children as well, each age group has its own general characteristics related to psychology and personality. Some children may cry when they see you because you're a stranger. Most should cry when they see you because you are a stranger unless you know them personally. Never let the potential for upsetting a child prevent you from delivering appropriate treatment if you need to. During transport, the child must be properly restrained in a proper child restraint device. Parents are welcome in most situations to ride with the child. They too must be restrained properly, and this allows you to better care for the child, because the child may be able to be calmed by the caregiver. And the caregiver can give you quite a bit of information about the child's history. Now, when interacting with the pediatric patient, you want to identify yourself and let the child know that somebody has called their parents if their parents aren't present. You want to assess them to determine whether or not any life-threatening problems exist, and if they don't, continue at a calm pace during your evaluation process. Depending on the age of the child, certainly a nearby toy or something that they would feel comfortable holding would be appropriate to give them to help them, comfort them, because more than likely they're going to be very frightened. You want to kneel at the child's eye level. You don't want to tower over the top of them. You want to get down to their level and speak in their language. A smile goes a long way. Touch the child's hand or touch their foot. Don't start using equipment without first explaining to the child what you're going to do to it. Let the child see your face. So you folks that think you got to wear dark sunglasses even inside the house, make sure that you take them off your face so the child can see your face. Stop occasionally to find out if the child understands what it is that you're going to do and what it is that has happened. Never lie to a child, because if they catch you in that lie, if you say, well, this is not going to hurt, and it hurts, you've just lost all trust and confidence in that child. The adolescent patient is old enough that they should be able to tell you exactly what happened and how they feel. They may not be completely communicative or cooperative in front of their parents or their peers. They are more sensitive to the opinion of their peers, and certainly they may be intimidated by their parents. They may be embarrassed or worried about what has happened to their body. They may see cuts and broken bones as being gross deformities that may make them hideous when they heal. So they have those kinds of genuine concerns about body image. In the adolescent patient, you don't want to delay evaluation and care because you or the patient may be embarrassed. It's something that you need to do. When possible, have the exam conducted by the same-sex person. If there's not a same-sex person that can do the exam, at least have a witness or a same-sex person with you if you're examining the opposite sex. Treat adolescents with respect. They certainly understand more than the younger children and can be an active part in their care and the decision of their care. Now, supporting the parents or other care providers is something that you may need to do as well, because, if you've got a caregiver whose child is just, broken their femur, they may be quite upset. They may react much like any patient who reacts to a serious illness or injury. They may have an immediate stress reaction that causes them to lash out, to scream, to be angry, to show self-blame or guilt. They may be in shock. They may deny this is happening to their child at all. They may get in your way and interfere with the care of the child, and that's something that we certainly can't let happen. And remember that not all children live in a traditional nuclear family with a mom and a dad. In today's society, certainly there are steps, blended families, there are two mommies, two daddies, those sort of things that we need to be aware of as well. Ask to help by holding or comforting the child and giving the medical history, so you can put the caregiver to work by, can you hold or comfort the child and give me some, answer questions about the child's medical history. Again, if at all possible, let a young child sit in the parent's lap or caregiver's lap while you do your assessment and provide care. So in assessing the pediatric patient, there's two viewpoints here. One is from the doorway, your first approach to the pediatric patient. The other is the remainder of the primary assessment that's done with a hands-on assessment of the patient looking for life threats. Now, from the doorway approach, we can use what's called the pediatric assessment triangle to conduct that. The pediatric assessment triangle includes us looking at things like appearance. Does a child look sick? We all know what sick kids look like. If the child is crying, if the child is clutching their caregiver, if they're looking around, they're moving their arms and legs, that's the appearance of maybe a hurt child, but certainly a child that's doing well. Whereas if the child is limp, lifeless, moaning, eyes aren't open, that's certainly the appearance of a sick child. Look at work of breathing. Are they working hard to breathe? Do you see indications that they're working hard to breathe? Nasal flaring, intercostal retractions, grunting, head bobbing, seesaw respirations, all those sort of things would indicate that this child is working hard to breathe and they may have a breathing problem. Look at their skin. What color is it? If it's cyanotic around the periphery, hands, toes, lips, those sort of things, that could just be because they're cold. But it could also be hypoxia. Look at their skin. Is it flushed or warm, indicating perhaps a fever? Is it pale, indicating perhaps shock? Determine if the scene is safe. You do that as you do any scene upon arrival, whether it's a kid or an adult. There's a rare risk from violence or abusive behavior, but sometimes caregivers may not want you to assess or treat this child, and may again get in your way, particularly in cases of abuse. You want a glove and gown and goggle, using standard precautions just like you would any patient, especially children who have fever, especially children who have rashes, because you're not sure what they have, but you don't want it. You want to evaluate the scene for clues of accidental poisoning, and if applicable, certainly call the Poison Control Center to get an idea of what you should do next. So here's that pediatric assessment triangle where we're looking at appearance, we're looking at work of breathing, we're looking at circulation to the skin to determine whether we have a respiratory problem or a circulatory problem or a combination of both. Looking at this child, certainly across the room, I would say his airway's open. I certainly would say his eyes are open. I certainly would say he's got rosy red cheeks. He's got a little smile, a little sparkle in his eye. Doesn't appear to be sick. So, probably not any immediate life threats either. Without seeing the work of breathing, there's no indication that the child's color's poor, or that they've got nasal flaring, or that they're working hard to breathe. You may have to maintain their airway, provide supplemental oxygen, assist their ventilations. Remember, because of their body surface area in relationship to their mass, that a child sitting there in a diaper, even in a room that's 85 degrees, they certainly could become hypothermic. So we want to make sure that we cover them appropriately. And then you may have to care for shock, and that is done the same way we care for any shock. Lie the patient flat, cover them to keep them warm, supplemental oxygen if that's what you need to do. Now, you can form your general impression after doing your pediatric assessment triangle. Is the patient sick? Is it respiratory, circulatory, or a combination of both? And then do my primary assessment, my A, B, C, D, and E. Your airway, is their airway open and maintainable? Does it need to be suctioned? Do they need to be positioned? Assess their breathing. Is it adequate? If it's inadequate, do you need to provide supplemental oxygen, or do you need to assist ventilations, or both? Rapidly determining whether the patient has any life threats is an essential component of the pediatric assessment. So you want to make note of their mental status. You want to make note of their environment as well as their emotional state, and then do your ABCs. Now, how the pediatric patient responds to you might be an indication of how seriously ill or injured they are. Again, they should be concerned about your presence, especially if they don't know you. They should have normal body tone, move their extremities well, should be upright and seated if they're being held by the caregiver. If they're laying flat, limp, not moving much, that certainly is problematic. If they're working hard to breathe, we talked about looking at those things to determine whether or not the child is working hard to breathe. And then if they're crying or they're talking, note the quality of that cry. Is it weak or ineffective, or is it loud and obnoxious? Certainly a very loud and obnoxious cry is a good indicator that the patient may be scared, may be injured, but everything's okay at this point. And then look at their skin color. As I'd mentioned, is it pale, flushed, cyanotic, those sort of things. We already talked about each one of these bullet points about the head being larger in proportion to their body, not well supported, so they could have spinal cord injury without damage to the bones. Their bulge of their fontanelles could give you an indication of whether they're dehydrated, hypovolemic, or they have hypertensive or a head injury. Again, foreign bodies can obstruct their airway easier because it's so small. You want to listen for lung sounds, for wheezing or grunting or gurgling or something that would indicate an airway obstruction. Their pelvis is not, again, children don't break bones easily because their bones are pretty soft and pliable. So, if you see a child with an obvious fractured bone, just know that took a great deal of force to do that. You want to look in their eyes, ears, nose, those sort of things for fluid, which might indicate a skull fracture. Look at their chest for equal expansion. If their abdomen becomes full of blood from an injury, you may see some bruising on the abdomen. It may be tender, it may be rigid or distended. If they have an acute abdomen, those sort of things. Now, it's difficult to assess the mental status in a pediatric patient, particularly if they can't talk. So we use ABPU to assess their mental status. Is the pediatric patient alert? Are their eyes open? Are they looking around? Do they recognize their environment, their caregiver? If they're not, do they respond to verbal stimulus? Do they respond to their name? If they don't, do they respond to some sort of painful stimulus that you might provide on tip of the nail bed or the eyebrow, or a trapezius pinch on the shoulder? If they don't respond to pain, then you want to tap and shout. We don't shake babies because certainly shaking infants and small children, we don't ever want to give the indication that we shook a baby or small child. So we're going to tap for unresponsiveness, and if they're unresponsive, certainly check breathing and pulse. If the airway is open, open it. If the airway is not open, we're going to open it. And then, is it maintainable? If it's not maintainable, we may have to maintain it with a jaw thrust, a head tilt, chin lift. May have to maintain it with a oropharyngeal airway. Be careful not to hyperextend the child's head because it could cause a complete airway obstruction. You want to extend the head so that the tragus of the ear is pointing at the shoulder. If the tragus of the ear points upward, then you're hyperextended and could obstruct the airway. If the child has a large occiput and you lie him flat, the tragus could point downward, which means the child would be hyperflexed and the airway could be obstructed as well. You want to assess their breathing with looking for nasal flaring, cyanosis around the lips or fingernails. Listen for any noises like stridor, which would be an inspiratory noise as a result of upper airway obstruction. Wheezing, which would be a expiratory noise associated with bronchospasm. Gurgling or crackles, which would indicate fluid in the chest. Grunting, head bobbing, intercostal retractions, all those sort of things would indicate an increase in work of breathing. Now, if they're not doing a good job of oxygenating all their tissue, the first organ to show dysfunction is going to be the brain. So if they have all these signs of an increase of work of breathing and their mental status is altered, then they are in actually respiratory failure. They may also have decreased muscle tone as a result of not getting oxygen to their muscles. You want to assess their breathing, looking for chest expansion, work of breathing, sounds of breathing, their respiratory rate. Understand that children's rates are much faster than ours anyway. Color, again, if they're cyanotic around the lips or the fingers, it could be that they're just cold. Put that into perspective with the room temperature and their skin temperature. Their skin should be warm, pink, and dry. If not, certainly flushed skin could indicate fever, pale skin could indicate shock, and cyanotic skin could indicate hypoxia. Yellow skin could indicate issues with bilirubin in younger children, or certainly could indicate liver problems in younger children. Feel for their pulse. Understand their pulse rates are much faster than ours as a general rule, and don't come to what ours are until they're in their adolescent years. You want to check for capillary refill. In children less than 5, that's probably a good indicator if they're in a warm environment. If their capillary refill is delayed, it takes more than 2 seconds, then that might be a good indication of poor circulation. Check for and control immediately any blood loss, because children can lose, they don't have to lose as much blood to go into shock. Here's a way to assess for capillary refill. Just blanch some skin by pushing it with your thumb and then remove it. The skin should be white when you blanch it by pushing on it, and it should within 2 seconds turn red again. If it doesn't, then there certainly is a circulation problem. You want to identify your priority pediatric patients, and those would be patients who initially give you a poor general impression. They look sick. They would be those pediatric patients who are unresponsive or listless. Those pediatric patients who are having trouble breathing. Those pediatric patients who have an altered mental status. Those pediatric patients who don't recognize their parent or their primary caregiver. A pediatric patient who's not comforted when held by a parent, but becomes calm and quiet when sat down, certainly might be of concern as well. High priority pediatric patient, somebody who has a compromised airway, if they have respiratory arrest or respiratory distress, if there's any potential for shock, if they have uncontrolled bleeding or have lost a significant amount of blood, they're a high priority. You can use a variety of devices to determine the size of the equipment that you might use, as well as the size of the oropharyngeal airway, that sort of stuff. And there are a variety of products out there. Pretty much it's understood that you can use a length-based colored tape, often referred to as a Braslow tape, where you go red to the head. So you put the arrow at the head and measure to the heel, not the toe. It determines the weight of the child. And with the increase in the size of our children, these devices are becoming less and less accurate. There are other devices out there, one called the PD wheel. So pretty much it's acceptable to use some sort of either weight-based device or length-based device to determine equipment that you might need for your pediatric patient. When you're doing a secondary assessment, patients, particularly younger patients, may only be able to answer simple questions, but you don't want to make them so simple. You don't want to make them closed loop questions where they can answer them with just yes or no. You want them to be able to explain to you in their words how they're feeling or what's going on. You're going to do a physical exam for a medical patient and a rapid trauma exam for a trauma patient. Some would advocate that you start at the feet and work your way to the head, but in any event, start where the child or the infant is most comfortable and work your way in one direction or the other. You want to get a good set of vital signs, and that can be a real challenge in pediatric patients, particularly if they're scared or hurt. It's very hard for us to get blood pressures on children, particularly those under 3. So, it might be more advantageous for you to assess the differences between their central and their peripheral pulses. Assess the difference between their carotid and their radial pulse. They should be the same. If the radial pulse or the peripheral pulse is weak, then there's a circulation problem. Again, they're saying take a blood pressure, but only in children over the age of 3, because it's really difficult to get blood pressures in children. Again, starting with the toes of the trunk and working your way towards the head might be a best approach with children. If there are no injuries, again, the patient can be held in the parent's or caregiver's lap. If you're going to remove clothing, protect the child's modesty, because even young children want their modesty respected. Explain why each piece of clothing must be removed and then put it back on when you're done with your assessment. When you're assessing or caring for the head, remember that we don't want to put direct pressure on the fontanelles. Meningitis, head injury, hydrocephalus, all kinds of things can cause bulging fontanelles. Remember that certainly a collision can produce a head injury, particularly in a child who isn't properly restrained in their child safety seat. Look for blood and clear fluid coming out of the nose and ears like you would an adult. You could suspect a skull fracture if either is present. Remember that it doesn't take a lot of mucus or clots to completely obstruct a child's ability to breathe because of their tiny airways. So if you've got a lot of mucus or a lot of secretions, make sure that you actively suction that airway. You may deliver oxygen by blow-by because an infant or a smaller child may not tolerate a mask put over their face or prongs put in their nose, even though they do make pediatric masks and pediatric cannulas. Your best bet of delivering oxygen may be blow-by. You may hold it about 6 inches to a foot away from their face and just flow oxygen in the general direction of their face so they do get a higher concentration while they're breathing. Children are vulnerable to spinal cord injuries because of their proportionally larger, heavier heads, but they don't have to break any bones in order to do that. They can have what's called a spinal cord injury without radiological abnormalities. So in other words, their ligaments can be stretched or torn. They can have whiplash injuries. They certainly can stretch or damage the spinal cord and not have any damage to the bones at all. They may have a stiff neck or be swollen on the neck as a result of that sort of presentation. Here again, we're keeping the airway in a neutral position, a sniffing position, where the tragus of the ear is pointing right at the shoulder rather than up or down. So we have them in a good position to open their airway. You want to maintain that neutral position. If there's no suspicion of spinal cord injury, place that towel under the patient's shoulders to get them properly aligned. When you're examining the chest, look for symmetry, look for bruising, look for paradoxical motion and attractions that you might see in a child who's working really hard to breathe. Listen for noises. Again, stridor is an inspiratory noise, which equals an upper airway obstruction. Wheezing is an expiratory noise that indicates bronchospasm, as in the case of asthma or anaphylaxis. Rhonchi or crackles would be indication of fluid in the lungs. Look at the abdomen. Note if it's rigid or distended. An abdominal injury may impede the movement of the diaphragm, which will affect the smaller children's ability to breathe since they rely heavily on their diaphragm to breathe. Check for stability of the pelvic girdle by compressing the wings together. We don't rock the pelvis, but push the wings together, feeling for any instability. Check the extremities for decap BTLS, looking for capillary refill, distal pulses, motor, the ability to wiggle their fingers or move their extremities, and whether or not they feel you. And you're looking at those extremities for deformities, contusions, abrasions, punctures, burns, all those things we've been taught to. Now, your reassessment of the pediatric patient is no different than the reassessment of your adult patient. You want to reassess critically ill or injured pediatric patients every 5 minutes, every 15 minutes if they're stable. And your reassessment begins with your primary survey. Your reassessment is like you've never seen the patient before. You start all over with your airway, your breathing, your circulation. I talked about D&E as a way of continuing your assessment in the pediatric patient. D stands for disability, and this is where you're going to look at their pupils to see if they have a head injury, check their AVPU, and if you have the ability, check their blood sugar. And then E is expose. Quickly expose them to look for rashes, look for fevers, measure their body temperature, and look for signs of abuse, and then cover them back up. You want to monitor their skin color, temperature, and moisture, reassess their vitals every 5 minutes if they're critical, every 15 minutes if they're stable, and then make sure that the appropriate care and treatment is being given. We have a tendency to over-triage kids, and that's okay. We have a tendency to do more for them than what they really need, and in most situations it's harmless. But in situations where you're going to administer lots of oxygen to a kid, if that's not something that they need, that can actually be harmful. So make sure that your treatment is appropriate. We're going to talk about some special concerns in pediatric care as well. Maintaining an open airway is difficult, as we've already mentioned in kids. Their tongue can cause an airway obstruction. The position of their head can cause an airway obstruction. Their airways are so small that any sort of secretions need to be constantly suctioned and cleared, and they need to maintain their head in a sniffing position. When putting an OPA in a child, it's most important to put it in normally. Just use a tongue depressor to get that big tongue up out of the way and slide that OPA in normally. We don't put an OPA in children like we do adults, where we start with the OPA upside down and drag it along the roof of their mouth and then turn it around, because that could cause some soft tissue damage to the child's soft palate, and there's no room for swelling in those tiny airways. So we're going to use a tongue depressor, or grab their tongue with a 2x2 in your fingers and get it up out of the way, and just place the OPA normally. NPAs, just like in adults, you're going to measure, you're going to lubricate, and you're going to place it in a child. Now, children who are have altered mental status but aren't completely unresponsive may tolerate this to help keep their airway open. Children may have partial obstructions of their airway. In this case, they're going to be able to move air. They're going to have a weak, ineffective cry or cough. As long as they're not cyanotic, you want to put them in a position of comfort, offer them some high-flow oxygen, and then transport. If they have a complete airway obstruction, we're going to remove that with the techniques we've been taught in basic life support, which include CPR. Here certainly is an infant with a severe airway obstruction using the alternate back blows and chest thrusts in order to relieve the obstruction. With children, you're going to do the abdominal thrust kneeling behind them, and then CPR if they become limp and unresponsive. You can provide supplemental oxygen and ventilations to children who need it. Again, you would know they need it because they have an increase in work of breathing. They may be cyanotic. Their SATs may be low. So giving them high concentrations of oxygen when they're in distress or in shock is appropriate. Just remember that a oxygen mask may frighten a child, particularly if they're having trouble breathing. They may feel like you're being suffocated, so you might have to use some blow-by. You want to avoid excessive ventilation with a pocket mask or a bag valve mask when ventilating a child. You want to give them just the amount of air necessary to make their little chest rise. You're going to have to work to maintain a good seal over the infant's face as well. If you've got leaks from the mask, you may have to use a little excessive pressure with the BVM in order to get their chest to rise. But as soon as their chest starts to rise, you need to quit squeezing the bag. Flow restriction oxygen-powered ventilation device or demand valves are contraindicated in infants and children because the oxygen comes out of there at too great a pressure. It would cause barotrauma to the patient's lungs. Again, you're going to know that they're getting enough air because you can visibly see their chest rise. You're going to know that they may have an airway obstruction because after positioning, suctioning, that sort of stuff, you can't get their chest to rise. Reposition their head, try to ventilate again, and if you can't get their chest to rise, they have a foreign body airway obstruction. Here we've already mentioned administering oxygen by blow-by. You can use a mask, but it's important that when you put a mask on a child that it covers their nose and their mouth without putting pressure on their eyeballs. If the mask is large enough where it covers the eye sockets, or you're resting your hands on their face, pushing down on the eyeballs of a child will actually slow their heart rate way down. So here's an example of ventilating a child with a pocket mask and a one-way valve using the thenar technique, where the thenar muscles of the thumb hold the mask on the face and 4 fingers on either side of the chin pulls the chin upward, lifting the tongue up off the back of the throat. Kids can go into shock. Rarely do they exsanguinate or bleed to death. They certainly can lose enough blood to go in shock, but it's not common for a child to bleed to death. Typically with kids, some of the more common causes of shock are going to be vomiting and diarrhea, so they become severely dehydrated, or an infection that leads to septic shock. Trauma, particularly injuries to the abdomen, if they rupture solid organs, those solid organs are going to bleed a lot. Blood loss is up there. Allergic reactions can cause shock. Poisoning can cause shock. Now, heart problems in children are extremely rare unless they have some sort of congenital defect. Signs and symptoms that a child are in shock. They may be listless, their eyes are glassed over, their mental status is altered, their skin is pale, cool, and clammy. If they're really dehydrated, they may not have tears even though they're crying. They have delayed capillary refill, their pulse is weak and rapid, their respiratory rate is faster than normal. They may see some seesaw breathing, some nasal flaring, some head bobbing, and the last thing to go would be a fall in blood pressure. And again, in a child this size, it's not likely that you're going to get a blood pressure. In caring for a child in shock, you want to ensure that they have an open airway. You want to manage external hemorrhage if it's present by direct pressure and even a tourniquet if that's necessary. Provide them high concentrations of oxygen. Keep them flat, but most importantly, keep them warm. It's so vital in patients who are in shock, regardless of age, that we keep them warm. Shock, by definition, is lack of adequate oxygenation. So they're not getting enough oxygen to their tissue. Because they're not getting enough oxygen to their tissue, they're not making enough energy. And if they're not making energy, one of the byproducts of making energy is heat. So they aren't producing heat either. So they quickly become hypothermic, which causes them to shiver, which causes them to use more energy that they don't have. And it worsens the shock. So it's vitally important to keep the patient warm and cover them when you believe that they're in shock, and then transport immediately. Protect them from hypothermia by covering their head. Keep the patient compartment at least 85 degrees. If the child is cold, handling them roughly can put them into a shockable cardiac arrest rhythm. And then whether or not you actively rewarm a cold hypothermic pediatric patient might be in your protocol, might be something that you'd call into med control to get orders for. Hypothermic pediatric patients are at risk of, if you take a 106-degree hot pack and you place it directly against their cold skin, they have a tendency to burn. So, I think what's most important in EMS initially is that we look at stopping any further heat loss. And then from that, we can look at perhaps active rewarming. All right, so that ends our presentation on pediatric emergencies part 1. If you have any questions, you certainly know how to get a hold of me. Talk to you soon.